Well, thank you very much for the invitation. The talk says DVT prophylaxis, but there's really only new agents for VTE prophylaxis or deep vein thrombosis and pulmonary embolism, but there really is only one agent that is approved for DVT prophylaxis for hip and knee replacement surgery. So I asked Dr. Rimmerman if it was okay, so I changed it to add treatment for DVT and PE. And these are about the NOACs, or the novel oral anticoagulants, and the question is, should they be used routinely? Good. I have also had a few disclosures I didn't disclose earlier. Sorry about that, Kurt. This is a little developmental history for you. Not many of us were around in the 1930s when heparin was introduced for practice, but and probably not many of us were around in the 50s either when warfarin was introduced. But you can see there's been an explosion over the last 2 decades of new anticoagulants, starting with the low molecular weight heparins in the 80s and 90s, the DTIs, or direct thrombin inhibitors, in the 90s, and then more recently factor Xa inhibitors, fondaparinux, earlier this decade, and over the last several years, the addition of Dabigatran, Rivaroxaban, and Apixaban, as you've already heard. So what are our current prevention options for DVT and PE, or VTE? Excuse me. We have the low molecular weight heparins, we have unfractionated heparin, we have fondaparinux, we have Ipravask, which is a direct thrombin inhibitor used in orthopedic surgery, probably not many of you have used, warfarin, of course, and then Rivaroxaban. And of course, we have mechanical means, intermittent pneumatic compression, and graduated compressed stockings. Well, these are the CHEST guidelines that say what are the current treatment options for VTE. Again, we have low molecular weight heparin and fondaparinux. We have IV or full dose sub-Q unfractionated heparin. Rivaroxaban doesn't have a grade at the time of the CHEST guidelines in 2012. It had not yet been evaluated. Of course, VKA, or vitamin K antagonists, in early administration. Thrombolytic therapy, filters, and compression stockings are all in the guidelines. So I'm going to talk just a little bit about should we still use warfarin for treatment, and here this cartoon says you are sentenced to Coumadin for life, which many of our patients feel at times. So should we still use warfarin, and what are we using it for currently? Well, certainly prevention and treatment of DVT and PE, atrial fibrillation, mechanical heart valves, arterial thromboembolism, and then thrombophilia or hypercoagulable conditions. But there are disadvantages, as you well know. There is a narrow therapeutic index. There's a need for frequent monitoring of the INR. There's a slow onset of action. It takes 4 or 5 days for it to become effective. There's large inter-individual dosing differences. There are drug-drug and drug-food interactions, and of course, genetic polymorphisms. And this is just a brief slide that's a little blurry to me, and it probably is to you, but of the drug and food interactions with warfarin. And as you all know, there are just very many of them. And of course, we have complications of warfarin. We have bleeding, we have new thrombosis, we have warfarin skin necrosis, we have warfarin embryopathy, and then one that's feared by many men, including myself now, is hair loss. So when you're on warfarin, you have to worry about that as well. So what are the characteristics of an ideal anticoagulant? It would be nice if it could be given orally and or intravenously. No need for routine monitoring. No dose adjustment needed for weight or size of the individual. Rapid onset of action. Predictable pharmacodynamics and pharmacokinetics. Minimal interaction with food and other drugs. An ability to inhibit free and clot-bound thrombin. Availability of an antidote. No unexpected toxicities, and appropriate costs. So these are the new kids on the block. We have 3 of them. Again, we have Apixaban or Eliquis, we have Pradaxa or Dabigatran, and Xarelto or Rivaroxaban. And these are a little bit about each of these agents. Rivaroxaban and Apixaban are factor Xa inhibitors, as you well know. Dabigatran is a direct thrombin inhibitor or a 2A inhibitor. Their time to peak effect varies from 1.5 to 3 hours. Their half-life varies from 4 to 17 hours, depending on the drug. Most of them, well, not most of them, I'm sorry, renal excretion is Rivaroxaban and Dabigatran, whereas Apixaban is more biliary excretion. And then there are no antidotes for any of these agents as of now, and the dosing varies. For Rivaroxaban, for prophylaxis, it's 10 milligrams once a day. For treatment, it's 15 milligrams twice a day for 21 days, and then 20 milligrams daily. And for the other 2 drugs, you can see the doses here, but neither of them are yet FDA approved for DVT or PE treatment. I think you just saw the pathway, the intrinsic and extrinsic pathway, but this just points out where these drugs interact in the common pathway. For the factor Xa inhibitors, a little bit higher in the pathway, and then the direct thrombin inhibitors a little bit lower in this pathway, but just a brief cartoon to let you know where we're at. Now, these are the novel anticoagulants, again called NOACs for VTE prophylaxis, and on your right are the trials. For example, Apixaban had Advance 1, 2, and 3, and then ADOPT, which was a medical prophylaxis trial, Dabigatran, Remodel, Renovate, and Remobilize, and then Resolve, which was medical, and then Rivaroxaban, the 4 Recurrent trials, and Magellan. Well, Rivaroxaban is a synthetic oral direct factor Xa inhibitor. You probably heard that earlier. It has no dependency on antithrombin. It inhibits free and clot-bound factor Xa activity. It has no monitoring required, but you can check PT time, and if it's prolonged, it suggests the drug has some activity. And more recently at the clinic, the main clinic campus, we've introduced an anti-factor Xa, similar to what we do for low molecular weight heparin. So we have that as a quantitative assessment. These are 2 articles published 3 or 4 years ago now, looking at Rivaroxaban for thromboprophylaxis in both hip and knee arthroplasty. And again, these are the Recurrent trials, of which there were 4. 2 of them looked at total hip replacements, and 2 looked at total knee replacements. Rivaroxaban was compared to enoxaparin in all of these doses, and the dose was 40 milligrams for 3 of the trials, and then one of the trial, Record 4, it was 30 milligrams of enoxaparin twice daily. The primary efficacy, Rivaroxaban was superior to enoxaparin, whereas the bleeding rates were similar in all 4 trials. And with that, the FDA did approve Rivaroxaban for total hip and total knee replacement surgical procedures. Apixaban, another factor Xa inhibitor, not antithrombin 3 dependent, no monitoring required. The PT and APTT may not be useful. Again, you could probably use an anti-factor Xa for quantitative assessment, and this anticoagulant has minimal drug-drug interactions. This is a trial published called the ADOPT Trial Investigators, looking at enoxaparin for thromboprophylaxis in medically ill patients. What it found was it was not superior to a shorter course of enoxaparin, and unfortunately there was a significantly more associated major bleeding with Apixaban compared to enoxaparin. This is a Dabigatran. It's an oral factor 2A inhibitor, or direct thrombin inhibitor. Again, it inhibits free and clot-bound thrombin activity. No monitoring required, but it may prolong the PT and or the INR, and it also may prolong the APTT, but again, these are not very accurate. The most sensitive agent to follow is a thrombin time, and so sometimes if you need to know if that patient's still on board, has Dabigatran on board, you can get a thrombin time. The best test is an Recurrent clotting time, but that's not available at most hospitals. And this was the Renovate trial. Again, Dabigatran is not approved for DVT prophylaxis as of this time. Now, as far as treatment, we have a number of trials that have been published over the last 4 or 5 years, the Einstein PE, the Einstein DVT, and the Einstein Extend trial, all using Rivaroxaban. And more recently, you may have seen in the New England Journal of Medicine the AMPLIFY and the AMPLIFY Extend trial looking at Apixaban. And then prior to that, there were the Recover, the RE-MEDY, the RE-SONATE, and the Recover 2 trial using Dabigatran. This is from the Einstein investigators looking at about 1,730 patients in both trials, or in both arms. Rivaroxaban was given again at 15 milligrams twice a day for 3 weeks, followed by Rivaroxaban 20 milligrams till the end of therapy, compared to enoxaparin, which was transitioned to a vitamin K antagonist with a minimal 5-day overlap. The p-value for recurrent VTE favored Rivaroxaban. However, the first major or clinically non-relevant non-major bleeding were almost identical in this trial. This just shows you that this was a non-inferiority trial with enoxaparin compared to Rivaroxaban. There's also the Einstein Extend study looking at Rivaroxaban 20 milligrams once a day compared to placebo. The numbers of patients were about 600 in each group. The recurrent event rates, as you might imagine, favored VTE, favored the Rivaroxaban, in which there were only 1.3% or 8 total events, compared to 42 with placebo. And the major bleeding rates were a little bit higher, but not clinically significant. The dosage recommendation I've already mentioned. You should avoid Rivaroxaban if the creatinine clearance is less than 30 mLs per minute. And if you miss a dose, it's important to administer the dose as soon as possible on the same day. And the importance of this, as you well know, is the half-life difference. So miss a dose of Rivaroxaban, you miss a lot. You miss a dose of Warfarin, you still have a little bit of time to catch up. I think you all well know that. Now, oral Apixaban was the AMPLIFY investigator trial looking at acute venous thromboembolic disease. Again, not yet approved, but the number of patients, about 2,600 in each group. The recurrent venous thromboembolic or death rates were very similar, but about 2.3% compared to 2.7%. Actually, it favored Apixaban. The major bleeding was also favored Apixaban, in which there were fewer major bleeding events. So again, this was Apixaban for 10 milligrams for 7 days, followed by 5 milligrams per day for 6 months, compared to enoxaparin and a vitamin K antagonist. This is the AMPLIFY Extend trial, again looking at 2 different doses of Apixaban, 2.5 milligrams per day and 5 milligrams a day, compared to placebo. And not surprisingly, there were many more events in the placebo group, but the numbers of events in the 2.5 and 5.0 milligram doses were exactly the same, and major bleeding was less. So extended anticoagulation with Apixaban reduced the risk of recurrent VTE without increasing the risk of major bleeding. We also have the RECOVER trial, the Dabigatran versus Warfarin in the treatment of venous thromboembolic disease, and these were pretty similar numbers, as you can see here. And then we also have extended use of Dabigatran in RE-MEDY and RE-SONATE, almost 680 patients in each group. The recurrent rate was much lower in Dabigatran compared to placebo. Again, most of these trials compared to placebo for long-term treatment, whereas major bleeding was higher, so it did carry a higher bleeding risk. However, the recurrent venous thromboembolic events were much lower. This is sort of a meta-analysis of, I don't know if it projects very well, but looking at relative risk for recurrent venous thromboembolic risk with the NOACs compared to vitamin K antagonists. And it actually it was almost similar comparing to Rivaroxaban, Apixaban, and Dabigatran with over 16,000 patients. So there was no major benefit compared to vitamin K antagonists. On the other hand, Rivaroxaban seemed to have fewer major bleeding risks compared to the other NOACs and vitamin K antagonists in this meta-analysis. And this is just a little slide I made myself because some of the questions that are often asked, what about patients that are over 100 kilograms? What about those with creatinine clearances less than 30? How about those individuals who have active cancer, thrombophilia? And what does this show us? Unfortunately, most of the studies did not look at that, although in the Apixaban trial, there were almost 20% of patients that weighed over 100 kilograms. And in the Rivaroxaban trial, there were about 14% of patients. 19.4% with Apixaban and 522 patients. So pretty good numbers. Creatinine clearance, the numbers were very low in all of the trials. No more than 14 patients in any of the trials had creatinine clearances less than 30. Active cancer, Rivaroxaban looked at about 118 patients, or 6.8% of the trials, and thrombophilia, again with Rivaroxaban, 107 patients, or 6.2% of the trials. So the jury is still out on what do we do with patients who have thrombophilia, active cancer, and those that are obese and with renal insufficiency. So who is a candidate for the novel anticoagulants? Patients who find it cumbersome to have their INR monitored regularly, or those individuals who INRs very fluctuates quite a bit. Patients who have a potential for food-food or food-drug interactions. In addition, patients with non-bleeding complications, those with perhaps warfarin-induced skin necrosis or hair loss or skin rashes. Patients that have a preference for the new anticoagulants, or physicians who have a preference for the new anticoagulants. So how do we monitor these new agents, the novel anticoagulants or NOACs? Well, I've already mentioned briefly that with Rivaroxaban, you can look at a PT value and it will tell you if there's Rivaroxaban on board, but it really won't tell you a quantitative assessment. And for that, now, again, at the Cleveland Clinic, we are doing a factor 10A assay to try and tell us what all this means. It will tell us certainly that the drug is on board, but there still are no guidelines as to what levels we need to use for monitoring Rivaroxaban. Unlike with heparin, if you do a heparin assay, it's 0.3 to 0.7 units per liter that you know about. And then if you do one with Lovenox, it's 0.5 to 1.0 units per ml for therapeutic doses. But yet, we do not know what the therapeutic dose will be for Rivaroxaban. We can only tell you what the levels are and that there's drug on board. For Apixaban, it's felt that this will be the same approach using a factor 10A. And then for Dabigatran, I already mentioned that the thrombin time is very sensitive. So if your patient's about ready to go to OR or have an interventional procedure, and you need to know if Dabigatran's on board, you can do a thrombin time, and if it's prolonged, that drug is still there. Eventually, maybe we'll have factor 2A assays and or the eccrine clotting time. So why do we need to monitor these patients? Again, I already mentioned that if they're about to go to an urgent surgical procedure or an interventional procedure, you'd like to know if the drug is on board. It'd also be nice to know if that patient is compliant. We might want to monitor them if we suspect an overdose. And then we would probably like to monitor them to find out if, what their levels are, if they are obese, if they're pregnant, or pediatric patients. Certainly, these drugs are not yet indicated in this population. We also want to know if they have severe liver disease or renal disease. If we can use these drugs, what can we use to monitor them, make sure that we're not over-treating them or under-treating them. We might want to know if other drugs are having an effect on their anticoagulant ability. And we want to know what their level is if they come in with a new blood clot and or if they're bleeding. So these are all reasons we might like to monitor the new anticoagulants or NOACs. Well, if you want to use the new drugs, how do we convert to them from other drugs? And this is sort of a busy slide, but in your left-hand column, if your patient is on warfarin and you want to convert to Rivaroxaban, Apixaban, or Dabigatran, you must obviously stop the warfarin and then start Rivaroxaban if the INR is less than 2.3. Now, this is a little bit lesser than what you might want to do if they have atrial fibrillation, but this is based on the RELY and RE-SONATE trial. If you want to convert from warfarin to Dabigatran, then wait till the INR is less than 2, and similarly with Apixaban. If your patient is on low molecular weight heparin and you want to convert to any of these drugs, you will want to start Rivaroxaban, Apixaban, or Dabigatran either 0 to 1 or 2 hours before the next scheduled dose, in this case evening dose, of the low molecular weight heparin. So you're going to be waiting probably about 24 hours. Or 12 hours if you're on an every 12-hour dose. If you are converting from heparin to one of the new drugs, simply stop heparin infusion and start any of these 3 drugs at that point. And then how do we convert from the novel anticoagulants back to other anticoagulants? Well, for Rivaroxaban, if you're transitioning back to another parental anticoagulant like low molecular weight heparin with rapid onset, stop Rivaroxaban and give the first dose of the parental anticoagulant at the time that the next Rivaroxaban dose would be given. And then this is a strategy, another busy slide, but if a suggested strategy for conversion from Dabigatran or Rivaroxaban to warfarin. And on your left is the calculated creatinine clearance, greater than 50, 31 to 50, and 15 to 30. Dabigatran, you would start the day with warfarin on day -3 before you think it would be time to convert. In other words, 3 days before you think you will stop your Dabigatran. Similarly, for Rivaroxaban, you would start 4 days before, start initiating warfarin, and then you can check the INR. The problem is it might be affected a little bit, so you might have to do other testing, such as at factor 2 or factor 10 level. And then what about bridging with the novel anticoagulants? This is something that probably comes up very commonly now because of, I think these agents are being used quite a bit. And this is a little blurry, the top line, but peri-procedural recommendations for Rivaroxaban, and this is based on renal function and the surgical or interventional procedure. So if your patient has a creatinine clearance greater than 30, we know the half-life may be as long as 13 hours. Standard risk of bleeding, and that would be defined as a cardiac catheterization, endoscopy, colonoscopy without removal of polyps, breast biopsy, or uncomplicated laparoscopic procedures, you should hold the drug 24 hours. If they're at a high risk of bleeding, that would include cardiovascular surgery, neurosurgery, abdominal surgery, and their creatinine clearance is greater than 30, then you should wait at least 2 days. And if they have renal insufficiency, which you would not normally use, as I pointed out earlier, if the creatinine clearance is less than 30, but if somehow they were on that, you would probably wait 4 days. And this is a general recommendation. If the patient was on Dabigatran, again, we have to base it on the renal function and the surgical intervention procedure, depending on the creatinine clearance, which varies from less than 30 to is greater than 80, then the half-life, of course, varies as well, and the standard risk of bleeding you would want to hold between 24 hours and 4 days for standard risk. And if they have a high risk of bleeding, again, if they're undergoing neurosurgery or cardiovascular surgery, you would hold between 2 days if they have normal renal function, and as many as 6 days if they have abnormal renal function, as you can see here. So what are some of the advantages to the new anticoagulants or novel anticoagulants? They can all be given orally. They have a fixed dose, so predictable response. They have short half-lives. They have rapid onset of action, so monotherapy can be approached. Therefore, no need to bridge with low molecular weight heparin or fondaparinux or even heparin for many of these invasive procedures. And it may allow for greater use of anticoagulants. Patients that don't want to take rat poison, as many of our patients may describe that drug, or those that don't want to be monitored and those that are concerned about drug-drug and drug-food interactions. And it may decrease the burden of care for the physician on one hand. We don't have to spend time trying to calculate the dose of warfarin that will be dependent on their latest INR. It may increase the quality of life for the patient because of drug-drug and drug-food interactions. So many of my patients say they can never have greens anymore, and I always correct them that yes, they can, but just to be consistent, there's no need to monitor, so they don't have to go down to the anticoagulation clinic and have their finger stuck or blood drawn. And then, although rare, Coumadin skin necrosis and heparin-induced thrombocytopenia should be avoided as side effects. So some of the disadvantages of the novel anticoagulants are NOACs. Some require twice daily dosing, so if your patient's not compliant on warfarin on 1 a day, they certainly won't be compliant on the new drugs that require twice a day dosing. Dabigatran has been known to cause dyspepsia. These drugs are more expensive than warfarin. They are not reversible. There is always a bleeding potential. An antidote is being looked at, but to date there is no antidote available. And then long-term data, we've only had a few months of experience with Rivaroxaban, and therefore long-term data is pending. These studies excluded, as I pointed out in that one slide, there weren't very many renal impairment patients, obese, pregnant, lactation, and pediatric patients. So we don't know about their use in those populations. And then what does one do if they bleed? Well, this is sort of a busy slide, and if it's mild bleeding, epistaxis or ecchymosis, maybe delay the next dose or discontinue or lower the dose as you deem appropriate. If there's moderate bleeding, such as upper GI bleeding, obviously symptomatic treatment, mechanical compression if you can, if it's an artery and you've got a pseudoaneurysm or something like that, or if there's surgical intervention that can be approached to intervene, fluid replacement, transfusion support. And if they've had these drugs within a few hours of ingestion, you can always try gastric lavage plus or minus activated charcoal. On the other hand, life-threatening bleeding, it's not real clear what we do. Rivaroxaban, and I put in parentheses Apixaban because that drug still is not yet approved, but if your patient was on it, if they've recently had the agent, you can again try gastric lavage and or activated charcoal if the drug was taken within 2 to 3 hours. And then there's the factor 3 and factor 4. I guess our factor 4 PCC, prothrombin complex concentrates, have just been approved. These have been tried in a handful of cases. They all carry the risk of thrombosis, which in the venous thromboembolic population would always be a concern, but if you're faced with life-threatening bleeding, you have little choice. Rivaroxaban is not dialyzable, and on the other hand, Dabigatran, similar approach, gastric lavage, charcoal, recombinant factor 7A has been tried, and the PCCs more recently have been tried, and then hemodialysis has also been tried. So it's a promising new drug with few side effects, and I'm sorry you find their TV ads offensive. With that, I'll end. Thank you for your attention.